It is 11:04. Which brings about the debate.
The debate?
The debate. You know what I'm talking about. Bruce Willis.
Oh, yeah.
Yeah. Is it a Christmas movie or not? Die Hard. Yes!
Yes.
Thank you.
Yes.
It's a Christmas movie.
Yes.
It is.
I would say yes. It's a great Christmas movie.
Fantastic.
You couldn't sign me.
You can go see the Cinesphere this week.
And do this at the same time?
I'm working on it.
Can't multitask.
You can go see it now at the Cinesphere. Die Hard on the big screen. Yes.
Where?
Cinesphere. Ontario Place.
Oh, yeah?
Where's that?
I don't know.
What's going on, son? Dr. Payne in the house.
DP.
That's
bad.
What's going on in your world?
What is going on in my world? It's never good. It's always people's aches and pains. It's funny. Every person that comes in to see me, when I I'll meet them, and then I'll say, "Really nice to meet you. How you doing?" And they always say, "Well, not good if I'm here to see you." And it's always like nobody's ever happy to see me.
But you're helping. Oh, by the way, it was nice to finally drop by the clinic this past week.
Yeah, great guy over here.
The place is beautiful. It's clean, which is nice.
Yeah.
Yep. Equipment's good.
Was the old one dirty?
I knew the old building. It's not your clinic, but that rest of that building's a little decrepit. But
well, yeah, a lot of these medical buildings are
archaic.
Yeah, they need renovating, that's for sure. So a lot of buildings need renovating.
Yeah, man. So if you're going to go by, the new clinic is nice. What's the address of it?
115 Humber College Boulevard, Suite 712. Now, that's where I do my assessments.
Yes.
But obviously, we've got places all over. So, but that's where I'm doing my assessments, which is Etobicoke General Hospital for people who know the area.
And you said you're expanding soon, too, in January, right? You're going to be.
So we're going to have actual clinics. We have a provider network across Ontario, but we'll have clinics that are operated by me, Brampton, Newmarket, Richmond Hill, and then Oakville and Vaughan shortly to come in the new year.
By the way, this is a call-in show. You have questions, concerns about your health, aches, pains, all that stuff. 416-870-6400 *640 on cell for the hour. Feel free to call in. Would love to talk to you. So anything interesting come by the clinic this past week?
Besides no.
Yeah. I didn't say weird.
Well, you're a good example. We can talk about your case. Why not? True. So, I mean, you tell us a little bit about your history. You've got a history of low back and neck injuries.
Yep.
And then your elbow's a whole different other monster, but we could talk about that too. But what happened? Let's talk with your neck. I think that's the one that caused you more problems over the years.
Historically, the back has been around longer as
the low
as
back.
We discussed. Yeah, the lumbar area. But the neck was an injury I sustained about 10 years ago in the gym. And at first I thought it was a pulled trap because it was sore for days. In fact, it was so bad when I was driving, I couldn't lean back in the car seat. I had to hold myself up on the wheel. Finally went for, I think it was an MRI and X-ray, and I've got a bulging disc on the anterior side towards the throat. And it's been, it's kind of been, it was bad at first. I had some atrophy in the right side, my right arm. It's more to the right side of the body. And then it's been manageable and okay and kind of dormant for a few years. But now, as reason why I went to see you last couple of weeks, it's been driving me nuts. My three fingers now, as we speak, are cold and numb. Not sleeping at night, wakes me up with pain and burning every night. So it's driving me crazy. Yeah. It's the neck. It's the disc.
Yeah, and that MRI was 2012. Is that right? Yeah. Yeah, I mean, there's evidence on that MRI for sure of disc bulges corresponding with the area. So here's a big thing, is it corresponded with what we saw in the physical exam room with where you're complaining of numbness and tingling, right? Because a lot of people, you might have, for example, a disc bulge at, I don't know, C3-4, but you have numbness in an area that corresponds to C7. So that starts to say, well, that really, maybe the disc bulge is not the problem. But you're a good example of imaging correlating with findings in the exam room, which is very, very important. That's why I don't like reviewing MRIs just on their own. Like sometimes people will send me MRIs and say, what do you think about this? It's like, I need to see you. I need to correlate that with what your symptoms are in the office, because you can see a lot of things on imaging that aren't significant. They may seem like they're bad, but they might not be significant. But you're an example of, yes, it correlated. Now, we don't have an up-to-date MRI, which we need to get you an up-to-date MRI. I can't
imagine it's better as you get older.
Right? Well, I wouldn't be surprised. So this is where you had a disc bulge. I wouldn't be surprised if now you've started the process of the degenerative changes, and this is more like stenosis type of presentation at this point, where maybe the bones have started to break down and you're starting to get osteophytes, and it's starting, and that's unfortunately a consequence of previous injuries, especially like disc bulges. That's the very reason why when you're younger, you're more likely to sustain the disc herniations and disc bulges, and as you get older, you're more likely to be affected by things like the stenosis, because it's just the very nature of those things. So, but with you, as we recommended, step one is get you a little bit of treatment. Just so you can start to eliminate the aggravation off the nerve.
I was thinking, and when I went home, that was the first thing. It's a disc bulge rather than, or at least...
I wouldn't say it's a disc bulge yet, though.
Okay.
I wouldn't say that, because clinically you didn't have symptoms of a disc bulge. What I think it seems more like is that area where you did have a disc bulge, you probably have a more arthritic process. Like, this is now 6-7 years ago, right? Yeah. So there's probably some arthritis that's developed, and that those osteophytes, which are extensions of bone that happen as a result of arthritis, are probably putting pressure on the nerve. That's probably more likely what's happening. But you still need treatment. Now, it's not significant to the point where it's going to affect your whole arm and all these things. But there is definitely an indication that I think that's probably what's happening.
Yeah, it's pissing me off. It's uncomfortable as hell, and it kills your sleep, so you have to treat it, right?
And now sleep, and that's a big thing too, because a lot of things are just as a result of nocturnal paresthesia, which is just positional too, right? It may also be that with the way you sleep, for whatever reason, pressure changes in the air as things get colder, things get warmer.
Good times.
It's very common for people to complain of these symptoms at night. But yeah, I definitely think you probably have some degeneration going up in the neck at this point that's probably putting pressure on the nerve, and so we got to assess that a little bit closer. I think start with a course of 3 weeks of treatment, just manual types of therapies to release the nerve throughout the different muscles, some traction on the neck, those types of things. Let's see how you are in 3 weeks, then we reassess.
So we'll look at that as a starting point, and after the break, we're going to get to your phone calls and somebody who's on the other side of having treatment with you. That's on the way here. Dr. Payne Show, 416-870-6400, star 640 on cell. Stand by. Coming right back.
Candles burning low, lots of mistletoe, lots of snow and ice, everywhere we go. Choir singing
I love it. You know what? That's payback, because last week he had a Dr. Payne idea.
Oh, did he?
Yes.
Yeah, it's okay.
Greg's loving this right now.
We're okay. I don't mind if it's Greg.
Yeah.
I'll take some of those calls. Yeah. I'll take those calls.
Why not? Oh, I always see you answer a transmission question. That'll be great.
I'll figure it out.
All right. I'm sure you will.
It's diagnosis as well.
Okay. Hey, Carlos, good morning.
Yes, good morning, gentlemen.
How are you?
Good morning.
Guys, everything okay?
Yeah, man.
Yes.
What's going on with you? Talk to us.
First of all, I wanted to say, John, you're a great host.
Oh, thanks, pal. I appreciate it.
Craig Carrasco.
Yep.
You and him make a great team. And also with the Dr.
Dr. Lou, DP. It's a good man.
But anyway, I'm in the landscaping gardening business.
Yep.
And I'm 51. And I've last year, I always had back issues as you get older, of course. But last year I just went to pick up a few wet rolls of sod, and I really had it for 2 weeks. I couldn't move, but it's okay now. But once in a blue moon, I get a sharp pain in the lower back. What is that? What could cause that?
Well, there's a lot of things that could cause that, and you're sort of the classic example of, and I don't mean this as an insulting, it's just to use it as an example of what people do wrong. So people will often feel these types of things, and they'll leave it because it goes away, and then all of a sudden it starts to creep up, it starts to happen more often, and then it becomes a bigger problem. When you start getting these early types of symptoms that seem to be transient and don't last very long, those are usually the best times for intervention, for when you should be seeing somebody, get a diagnosis, figure out what it is and how do you manage it. So all we really know is you have low back pain and it shoots down into your leg potentially. that could be due to a lot of things. That could be something like a disc bulge or disc herniation. Could also be just muscular issues. It could be nerve tension due to other things. So there's dozens of things that can cause that type of presentation. Most likely, it's either a muscle or a disc issue. But it's very important to identify and distinguish between those two and figure that out. Because, I mean, you're still, number one, once you figure these things out, you can figure out what are the things you should be doing and the things you shouldn't be doing, which means how do you modify your work so that you can work and minimize the occurrence of these types of things.
Yeah, like I do, like, because, our workload is mostly in the summer.
Yep.
But we do also snow removal in the winter.
Right. Yeah.
But in the winter, when there is no snow, I try to do a routine workout. Like,
good.
Muscle building workout.
Yeah, good.
Because I know as you get older, your body needs that, and I try to eat as properly as I can. But I'm always looking at the back because I've had back issues before,
right? And
it's caused me to really, sometimes just lay on the floor for 30 minutes at the job site just because that's certain.
And have you ever had this looked at,
no.
Carlos? Yeah. So I think you're already it's good that you're already being active, but maybe this could be as simple as someone just giving you the right exercises that you should be doing day to day and helping to prevent these things. So you need to get this looked at. I'm happy to do that for you. And we need to figure out, okay, what's the most likely cause here? And then once we know that, then you manage it accordingly. That's an important thing because not all symptoms are a result of the same diagnosis. So you can have the same symptom be related to multiple different diagnoses, like low back pain with leg pain.
Would that be inherited, the back pain?
Well, yeah, I mean, everything is genetically somewhat predisposed, not because there's a gene for back pain, but it's usually due to the genetics for body type and structure and things like that. So, yeah, of course, it can be somewhat hereditary.
Yes, okay.
Yeah.
My father does, because he did the same job I did, and and he had the
probably fairly common.
Well, and it is common in your line of work, like the construction-based work, especially landscaping, things like that, because a lot of it is bending, lifting. Sure. That's a very common, but it's not any more common than if you were sitting down and working at a desk. There's
exactly like sometimes it's just to pick up a piece of paper and your back goes.
Oh, but been there, brother.
Yeah.
Yes.
Yeah.
But anyway, thanks for all the information.
No problem.
God bless you guys.
Thanks, Carlos. Have a wonderful Christmas. 1-855-55 Lou, by the way, info@paincarecanada.com to reach out. You know what? Let me start. We mentioned the first time. It's going to be an interesting test now that I'm going through the clinic for personal reasons, how I start from zero and see how much better
he doesn't refer his mother-in-law comes after 2 years.
Dude, you're going to thank me. Okay. I'll let you know if that's going to happen. I'm going to get to my I have a family member, though, that has been through the ringer now, had some pain, and I know Courtney's just getting her set here.
No problem.
And off the top, I told her that, you're going to get into this, but you're going to get into it full bore and stick to it. Because
I haven't talked to her in a while, but this will be a good example because I've only seen her once and given her recommendations on what to do.
Okay. So my sister-in-law, Cammie, is standing by. We're going to get to her after a short break, and maybe this will reflect positively on you as well if you're listening. Possibly. Phone calls as well, 416-870-6400, star 640 on cell. Stick around. Lots more to come. Dr. Payne Show, Global News Radio, 640, Toronto.
Christmas Eve, babe, in the drunk tank, an old man said to me, won't see another one, and then he sang a song, the rare old mountain.
It is 11:21. More of your calls coming up. 416-870-6400, star 640 on cell. 11:21. We go right till 12 o'clock. Now, my sister-in-law, back problems a few weeks ago, and I said, you got to go see Dr.
More
Lou.
Than a few weeks now.
Yeah, I guess so, right? And I said, you got to listen to him, and you got to do what he does, do what he says, and be diligent. Cammie, good morning.
Yeah.
How are you?
How are you guys?
You sound different than you did 3 months ago. What's going on?
God, it's a miracle. I saw Dr. Lou back, I think, what was it, about 2 months ago? And it was like, I think you did some stuff on me and tests, whatever, and recommended plank, recommended the pelvic tilt, and I have to say,
and you've been doing them?
Oh my God, every single night since that day.
Yeah, and you're a testament, and a lot of people will thank me, but there's really nothing to thank me. Like you're a testament. I saw you one time, and I suggested the right things. I used my knowledge to give you the right things to do, but you should credit yourself because you're doing it every day, and if people do those things every day, then they get better. That's just the reality.
Well, it's funny because I was listening to the last caller, and he was saying how he was having symptoms and didn't do anything about it, and that was me.
Yeah.
But a month before that, I was getting up with pain. I figured out it's probably nothing, and it got worse and worse. If I had maybe taken it, at the time, I probably would have been better earlier than what I, when I got better.
Yeah, and those things progress. Like, I mean, very quickly for some people, it's like the last caller where it progresses over years, where it's a history of it, and it's mild, then moderate, and then severe. For some people like you, Cami, it progressed quicker. But the biggest thing that I always try to get across is early intervention. The beginning phase of the intervention is usually some type of passive therapy, which is like the things you were doing, the physio, chiro, those things. But the long term, once you're out of that initial acute pain phase, and then it's all about what you do on your own every single day, the right things that you do, the things that you avoid. And if you do that, then the outcome is exactly like you're describing. You'll feel, and I mean, you will also tell me, like, most people that have these things, you don't get quote unquote cured. This is you're managing it, but at least you're able to live your life day to day, and it's not affecting you from doing the things you want to do.
Exactly. Well, that's what I was afraid of, was getting back to that severe pain that I had before. So not wanting to ever have that, I just kept, diligent with doing the exercises. And my physiotherapist sort of graduated me a couple of weeks ago into more intense stuff, like challenging things. Yep. So it's really working. And Pilates actually is the next step. I've done a couple of times Pilates, but if I'm going to do it on a weekly basis, it's amazing. But you, I have to say, though, if I hadn't seen you, I wouldn't have known what to start with.
Yeah,
so,
well,
the starting point was what would have helped me big time.
I'm happy that you're doing better. That's the most important thing.
Cami sounds completely different.
The only thing I can't fix is who your brother-in-law is. I don't control those things.
No, but if he had recommended I see you, honestly, I would have known what to do. And I kept doing the same thing, physio, over and over again. So this is actually the starting point for me getting better.
Good.
And I've been so good for the last 2 months, just doing stuff every single night. I never want to get back to that pain.
Does it feel like, when we had this discussion a couple of weeks ago, I said, a lot of people, unfortunately, they think it's a course. I'll do this physio, then I'll stop it. I said, it's like brushing your teeth. You're going to do it for the rest of your life. And now
you
might stop the actual passive therapy, right? Like getting machines put on you, someone else walking you through these things. But what Cami said is very important. She's progressing with the exercise because your body adapts. If she was still doing the same exercise she was doing 3 months ago, she would still be feeling. It's better than not doing anything. Yes, 100%. But she wouldn't be getting better. It's always important to challenge your body to prevent adaptation. And so, Cami, I think it's great. These are the stories that I like to hear. This is what I hope we get across with the show, that the onus for people's management of their aches and pains also falls on them. And this is Cami's the example of that. Like, you can't expect to take a pill, have someone do something to you, and that's the solution and that's the be-all, end-all. No, there has to be a component that you're the bigger component because you're doing it every day.
Well, that's what she said. She said, I don't have to see you anymore. So maybe come once a month, maybe come twice a month.
Oh, perfect.
It's all about you getting stuff done. So it's working. It's really working.
Awesome.
Now, I told Dr. Lou this was just a warm-up because he really wants to see Mom. He wants to bring Mom by, and I said, okay.
Oh, yeah.
Okay, good luck, buddy. You're going to earn your degree now.
That'll be a lot of work.
That's a lot of work.
It's a good test.
Yeah.
Yes,
Cami, appreciate it, all right?
So much. Yeah, you guys have a Merry
Thanks,
Christmas,
Cami. You too.
Take care.
And I'll see you like in like an hour or something like that. I don't know. We'll get to Jane. Hey, Jane, good morning.
Good morning, and thank you for taking my call.
No worries.
This has been amazing listening to this program. I've got one herniated disc in my neck and 2 in my lower back, and this has been going on for over 3 years. Mm-hmm. I just take opioids, which I'm prescribed for the pain, but I really cannot hold my head up, and I look ridiculous, and it's embarrassing. And if Dr. Lou could suggest anything that I could do.
How old are you, Jane?
I'm 58.
And so you can't hold up your head?
Well, hardly.
Now, is that because of the pain is positional or because of loss of strength?
I think loss of strength. It feels like there's an invisible hand behind me pushing my head down.
Okay, and you've obviously seen people about this, I'm assuming, right?
I've had many MRIs, many physicians, but no one has suggested anything that I can be proactive with.
That's absolutely wrong. You have to be being proactive. It's just a question of what are the proactive things that you need to do.
Right.
And that's hard for me to answer, without assessing you. So I would say the most important thing that you can do is give me a call after the show. We'll set up an assessment.
I'd like to do that very much.
And we'll take a look at it and we'll figure out, okay, well, what's going on? Likely when people, so here's the thing too, when people have a true, and I'll use this term, quote unquote, true disc herniation, those things are debilitating. So a lot of times people have an initial acute phase by a disc herniation, and then once the pain of that wears off, they still have the chronic aches and pains.
Yes.
And that's probably what you're dealing with now, because most disc herniations don't last for 3 years, that acute phase.
Right.
So you're dealing with the aches and pains associated with having had an injury, but not necessarily due to the disc itself anymore. So it's important that we figure out, well, why is there still some ache or pain there? I mean, if you're describing that your head, there's loss of maybe of strength, or that there's pressure that prevents you from going there, then obviously we need to take a look at, well, what is preventing that? But I can tell you to just be on opioids. That is part of the management for sure with pain,
right.
but it's one portion of it.
It honestly feels like there is an invisible hand pushing
right.
my head forward.
Okay.
It's creepy, actually.
Now you can, if you need be, you can bring your head back. You actually have strength, though. I'm just trying to understand. You just yes. Okay. That's
I have to consciously put my head back.
Right.
But then it just.
Do you have weakness anywhere else, or is it just there?
It's there.
Okay. Yeah. Which levels were the disc herniations at? 5, 6, and 6, 7 in the neck?
I'm trying to remember. I can't remember.
Probably most like they tend to be more likely towards the
spine and one in the neck.
Yeah. Right. Yeah, and those are the most common areas for the disc herniations. How did you do it? Was it a traumatic incident or?
No, and that's interesting. I woke up one morning and I could not walk.
Right.
I just woke up. I tried to get out of bed. I couldn't walk. So I don't know. And I had done nothing previously. No heavy lifting. You know what I mean?
Have you ever done therapy or anything like physical therapy, or has it always just been management with medication?
I went for acupuncture initially because I literally could not walk.
Right.
And there's an acupuncturist who is local, and my husband had to carry me to the car.
Right.
Take me there. That's all I've done, though, and I'd like to be proactive.
Yeah, you probably need to be doing more, and this is a good example. This isn't even your fault. It's a gross mismanagement of these types of things in the healthcare system. It's very, very sad. I saw someone the other day, very similar story to you, had been going to suffered a low back injury, had been communicating only with the family doctor, and the family doctor just kept saying, it'll get better on its own, and progressed to the point where, this person's life has fallen apart. And if you've been living with pain for 3 years, you know how much it can affect every aspect of your life.
That's exactly the spot that I'm in right now. And when I started listening to the program, I said to my husband, I have to call.
I'm happy you did. Yeah. So give me a call after the show.
What number?
No, I'll give it to you.
There. Go. Okay. Or else there's no point to John if he doesn't.
I got to do something. I mean,
Sorry about that.
Jane, appreciate the call. The number's 1-855-55 Dr. Lou, DRLOU. Again, 1-855-55 Dr. Lou, or info@paincarecanada.com. More of your calls, 416-870-6400 *640 on cell. Got lots of room. Come on in. Dr. Payne Show till 12 o'clock. Global News Radio, 640 Toronto.
It's beginning to look a lot like Christmas.
It is 11:32 on the Dr. Payne Show.
Greg's not listening right now if this music's on, right?
I hope his car is jammed on the station and he can't turn it off. I might call him in the middle of the night tonight. Just hold this up on the phone.
Just hold that there. Just send him all kinds of Christmas messages.
Totally. Get some carolers to his front door. Hello. Silent night. Skulls, you son of a. Get to Larry. Hey, Larry, how are you?
Good, thanks. I just turned 64. I'm very, very fit.
Good.
I've had trouble with my feet for probably 25 years. They told me at one time it was plantar fasciitis. osteoarthritis. In the last 2 years, I've seen different doctors, and the last doctor said I may have Morton's neuroma in my right foot.
Okay.
For one thing, I used to run a lot on the sidewalks, and like for years, and I also worked in construction, on concrete for years and years.
Right.
So maybe there's some damage there. Is there anything I could do to alleviate the pain, or because I'd like to continue working out?
Yep. I'd have to figure out what is the symptom besides foot pain? Is it just pain, or is it numbness and tingling?
It's tingling and pain.
Right. Yeah. So there's a lot of things that can cause that, all the way from something local like a Morton's neuroma, which is sort of a pressure building on the nerve in the foot, all the way to entrapment of muscles in the lower leg, to entrapment of muscles in the upper leg and the glute area, as high up as problems within the spine itself. So the first step here is figuring out, okay, you have a symptom, and as I was talking about before, the same symptom can apply to many different types of pathologies or injuries or whatnot. And so we need to identify, fine, you have this set of symptoms. Where does it fall? What is this? Because I can't just give you, well, what is something you could do to manage it if I don't know what the cause of the symptom is. And so we need to figure out what the cause or the most likely cause of the symptom is, and then once we have that, then we can identify what are the things that you should be doing to help alleviate or manage this issue.
Okay. Thanks very much.
No problem.
Larry, that call, 1-855-55 Dr. Lou, DRLOU. No, it's amazing. All the way down to his foot, and you mentioned all the way up to the spine. It's like you almost have to liken it to, people don't realize that the nervous system is like,
it's all connected.
The New York subway, you start at Grand Central, but you get all the way up to Queens or up
go on Google and type in the human nervous system.
And look at it.
And it is your brain to the spinal cord and then all of the nerve roots that go out. And we're talking about a lot.
Yeah, it's a lot. Crazy.
Yeah, and you're right. It's like a subway. But that's everything. If we looked at our vascular system, same thing. So when you have a nerve type symptom, right, and you have to look at that map and determine, okay, well, where's the problem coming from? Because it doesn't just because you have a problem in your foot, and this isn't true only for nerve issues, just because you feel pain in your foot, for example, does not mean the cause of the pain has to be in the foot.
The problem is the foot.
Right. Might be the leg, might be the upper leg, might be the glutes, might be the back. I mean, brain tumors, for example, can create symptoms in your foot. Now, that's likely not the cause in this gentleman because of the long history. But I'm just saying, trying to make someone I'm just trying to highlight the extent of the way I look at these things. When someone says, I have a set of symptoms, I start to get like a Rolodex in my brain of all these different things that can cause that type of symptom. And that's the right way to look at it.
Yeah, it's kind of weird, and I guess it speaks to, if you look at acupuncture, they put needles in your foot and it alleviates a headache. Weirdest thing, but that's the way it works, right?
But the nervous system communicates. It's a back and forth system. You have communication from your peripheral body, which is your body, to the brain, but you equally have information going back from the brain to your body. And so, absolutely. And that's why a lot of those things, more traditional alternative medicines like acupuncture, work so well, because it's neurological. It's a way of of sending back something to your nervous system. It's pretty incredible. And there's a lot of good research around acupuncture too, in terms of why those things work, like why certain points will do certain things. It's pretty incredible stuff, and it works.
Talk a little bit about the assessment, the process.
It always starts with the consultation, which is done via phone or send me an email. Point of the consultation is not to give a diagnosis or a plan of management or figure out what the issue is. It's just simply to identify, am I or my team the right person or people to be helping you with this problem? We've had calls before where people talk to us about urinary symptoms, for example. We don't deal with that stuff, but I'm happy to take the call anyways. I can help point people in the right direction. And so that's step one. If I think it's if it's something that me or my team can assess, then I will suggest that you come in and see me for an assessment. 99% of people see me for the assessment. In the event that someone needs an assessment today, for example, like after the show, because it's an acute issue, my hours are limited. I'm booked up, but I have a team. So we have other people that could assess you. But 99% of people want to see me and they can wait a week or so. Obviously, if it's urgent, and you need to see someone today, then you should make the exception and see someone in my team, of course. And then we'll set you up with an assessment. And then that assessment, we go through a detailed history, physical exam, and then start to figure out what's the plan of management here. Like, what is the diagnosis, the differential diagnoses, and how do we go about treating whatever it is that the person or you have? And we come up with a game plan, and that's it. And that part changes depending on what the issue is. Like, some people will say, well, is that covered by OHIP? Well, it depends. If you have to see a surgeon and have surgery for, I don't know, whatever, torn labrum in a shoulder, for example, and then, yeah, that's covered by OHIP. But if you're going to get therapy because you need, therapy, Cammie's a good example, then that's private insurance or out of pocket. Or sometimes people are involved with a third payer, so it might be like a work accident. Yeah. So then it's a WSIB claim, or it might be a car accident, and so it goes through the car insurer. So it depends. I can't give a cookie cutter answer to that one. So it very much depends. But if you're wondering what the right answer is, just give me a call. That's the simplest way.
1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. Take a short break. Got time for you to call in, have your questions answered as well till 12 o'clock. That is 416-870-6400 star 640 on cell. Dr. Pain Show, Global News Radio 640 Toronto. It is 11:41. Still have time for you. 416-870-6400 star 640 on your cell. It's the fact that we are a bipedal life form. We walk around on 2 feet. Feet take a lot of stress. I know you get a lot of foot people, right?
Things.
Don't you?
Yeah.
Isn't it good?
Yeah, of course. Foot pain is huge. Now that we're going to start talking about it, you'll see. But yeah, foot pain is something that affects everybody because that is how we
it's your contact.
It's how we get around. And so there's the most common type of foot pain, which is due to plantar fasciitis, and that's just really,
what is that? For those who don't know, we've all heard the term.
Yeah, it's sort of a wrong term because there's not a lot of inflammation that actually happens. It's more tearing in the plantar fascia, and that causes pain. But there is some research that suggests it is inflammation, so it's kind of torn there. But a lot of it just has to do with position of foot people that are flat-footed or high arches.
Is it a muscle thing, a joint thing? What is it?
Yeah, fascia. There? Fascia is the covering of muscle.
All right.
So there's a muscle at the bottom of the foot, and it's covered by fascia, and that is the plantar fascia. And so when there's irritation in that fascia, that is what we call as plantar fasciitis. And that could happen at any age, at any point in life. Some people get it and it's short-lived. Some people get it and it's there forever and very hard to manage. But it affects a lot of people. Some people have it because of heel spurs. Then you've got the other problem with foot issues is because plantar fasciitis is so common, a lot of times people don't have plantar fasciitis and they're just told that they are because it's the most common thing. It's like you go somewhere and it's like, I've got pain at the bottom of my foot. Oh, it's plantar fasciitis.
Yeah, I got back pain. Sciatica.
And that's like that previous caller is a good example of maybe it's been wrong all these years. It's not plantar fasciitis. Maybe it's a nerve issue creating a similar type of symptom. And so you've got things like plantar fasciitis. He mentioned Morton's neuroma, which is another disability that can affect the foot. Some people are flat-footed, and that can create symptoms. Some people
Does structure affect it? For instance, someone say your height, say at your height now, say you're flat-footed. I'm 6'4.5". I got a very high arch. Would it make a difference with plantar, or it doesn't discriminate?
No, I'm trying to think of the right answer here. I don't think it would discriminate. Right. No, I think a lot of it has to just do with what the person is doing. You do find it to be more common as people become more active, right? So that they're using their foot more, so stuff's breaking down. They might also be doing things with their foot the wrong way from a functional perspective or not an ideal way. It could be related to footwear. Some people just get it as a result of wearing some different type of footwear that their foot's not used to, and then all of a sudden
bad footwear.
Or
your whole
that's
life
what
in
I mean.
chucks.
Yeah, exactly. Yeah,
right.
Yeah, not tying your shoes, things like that, and so for sure, those types of things can lead to foot pain and plantar fasciitis specifically. Sometimes it's also you can get what's called like a fat pad syndrome, which the heel of the foot is surrounded by a pad of fat that can inflame sometimes just due to pressure. And a lot of times that's like you're told it's plantar fasciitis, but it's not. So it's important that you figure out what the right diagnosis is, which is sort of the theme of this whole show all the time.
416-870-6400, star 640 on your cell. Vlad, good morning. What's up?
Good morning. I have a pain in my back, just basically from sitting down. I'm fine if I'm walking or lying down, but if I sit at work or the dinner table or in a car, it hurts to sit. And I have trouble describing it. Maybe I was hoping you could help me describe it.
Well, I don't know that I could help you describe your pain. No, I can, in an assessment, we can go through those things. But pain with sitting, but walking around and doing other things is fine. How long has it been going on?
It's been getting worse over a year, probably.
Okay, but you've had low back pain most of your life?
No, it started with sciatic nerve, I think it's called, when it shoots down from one side of the back towards the thigh.
Yeah.
But this is kind of different. It feels like a tight belt,
Yep. How long, or have you seen anybody about this?
No, I haven't.
No, so yeah, that's problem number one. That's it's got to start there. You got to see a professional who can look at it. As I've said, now many times that. It's a symptom, right? And many things can cause the same symptom. And if you don't identify the cause of the symptom, then it's very hard to ever identify what the right thing is to do. So it's back pain. Back pain is a spectrum of dozens and dozens of different things that can cause back pain, some more common than other. I mean, 90% of back pain is what we would term as non-specific mechanical low back pain. The answer to that is often the proper rehabilitation. So, you have a 90% chance that that's what it is just because that's the stat, but I can't tell you for sure without assessing you.
Right.
Okay, I have a quick question, though.
Yep.
I was going to different workout classes for fitness. I stopped doing it to see if it would make any effect. It hasn't had any effect.
Yep.
Can I continue doing fitness, or should I prevent this, or should I not do it until
Same answer. If I don't know the issue, how can I possibly make an appropriate recommendation? It's hard for me to say.
Okay, I understand.
Okay.
Thanks, Vlad. Appreciate that. Reach out, indeed, and go see Dr. Lou, 1-855-55-Dr. Lou, DRLOU. Moving on to Dan. Hey, Dan, good morning.
Hey, guys. Merry Christmas.
You too,
Merry
sir.
Christmas.
Great show, Doctor. Thankfully, I'm not in need of your service, and hopefully I never will.
Okay, good.
But I'm asking a question on behalf of this female friend of mine, and I guess for all women. I told your screeners, what is the short-term and long-term side effects and pain issues related to women wearing heels?
Yeah.
Yeah. I mean,
I've never heard anybody really explain, but how can that something be so unnatural, not have consequences?
It does. It has consequences for sure. I mean, one of the big things, like when you look at bunions, right? So if you look at the position of a foot, a bunion is essentially how would you describe it? Like a bunion,
like a hard
but the deformity in the foot that happens, like what I'm talking about when I say bunion, right? So you have women in high heels, so your foot is elevated at the back, in the front, and the front is pointy, and then women wonder why they get bunions. It's like, well, you've set your foot up to do that, so of course you're going to get a bunion as a result of that. Now, a lot of bunions are also just simply genetic, but for some people it's not. It's created by the footwear that they wear. But yeah, it absolutely has consequences, but that's sort of our life, right? Like we're subject to all these sociological things that are supposed to be proper, but they're usually not good for us in some way, in one way or another, or not good in excess anyways. I'm not saying that women shouldn't wear high heels, but absolutely, if you're wearing high heels every single day, and most women will tell you that it's hard for them to do that.
And luckily the workplace is changing where it's not deemed, you could wear whatever the hell you want to make your health
exactly.
better.
In a lot of places, they'll wear flats or things. But some of those flat shoes that women wear are just as bad as the high heels too, because of the lack of support and those things. So that's also a monster on its own. But yeah, in general, the footwear that we have is tailored more towards style than it is appropriate ergonomics for the foot, unfortunately. And so, yeah, your point is very, very valid. But do I have stats on what the likelihood of wearing high heels is to causing pain? No, but I could tell you from what I've seen in practice, it definitely is related.
No, because have you have clients who have come to you? Because my friend, she can't even wear heels anymore.
Yeah.
So is that something like where if she came and saw you, you may be able to help her diagnose?
Potentially. Yeah, it's very hard to ever make a promise on, we'll get you. I've had people that are high-end soccer players. They come in and that's like me saying, before I see them, can you promise that I'll be able to play soccer again? Yeah. I don't know. I'll have to take a look at it. What I do make everyone aware of when they see me are the pros and cons to doing the right and the wrong thing. So I don't force anybody to do anything. I just simply make them aware of what the right or what the ideal course of action is, but then it's always up to the person. I'm not in the business of telling people you need to do this. I just make them aware that if you don't do it, here's what happens.
Right, but I'm just saying, have you ever had clients?
We've been able to help people that's all. That's everything that we do is we help people manage their issues so that they can live the lives they want.
Right.
It's a good slogan, actually.
I'm gonna have her give you a call. But thanks.
Okay, no problem.
Great show, and once again, I hope I never need your service.
Okay, no problem.
Thanks, Dan. Appreciate it. Enjoy your Christmas as well. You set the table. It's up to them if they want to sit down and eat, right? That's the way it works. So true. 416-870-6400 star 640 on sale. Still got a few minutes left to get your call in there. And the Dr. Payne Show, Global News Radio, 640 Toronto. It is 11:52. Go till 12. You can reach out afterwards, of course, anytime. 1-855-55-Dr. Lou. That's DRLOU. Info at PayneCareCanada.com. Robin, thank you for hanging on. How are you?
I'm good. How are you?
Great. Go ahead. What's your concern?
Okay. Thank you so much for squeezing my call in.
No worries. No problem. Got time.
So back in May, I had a bit of an injury at the gym and was diagnosed at that time with a lateral meniscus strain on my right knee.
Sorry to interrupt. How was that diagnosed?
I went to a physiotherapist.
Okay.
And then after a full assessment, they deemed that it was in fact not torn, although it certainly felt like it at the time. It was horrible. So they diagnosed me with a lateral meniscus strain, put me on a pretty rigorous physiotherapy program, which also included, continuing with my workouts at the gym, just heavily modifying things like, you have to be careful with squatting. I had to be careful, no running, nothing with any impact on the knee whatsoever. And it has progressively been getting better.
Good.
But I'm definitely not 100% there yet. Obviously a little bit frustrated because there's certain things I still can't do. Like, I got to be careful with running. I'm still not doing burpees. I'm still not able to do, some of the things that I could do before.
Mm-hmm.
And then, so I guess my question is, in your experience, how much longer do you think this is going to take? And am I on the right path in terms of following sort of an active...
So tell me again, when did this happen? Sorry?
This was in May.
In May. So here's the stat I'll give you. Okay. Most simple soft tissue injuries, right? So soft tissue meaning anything that's soft tissue, obviously muscles, joints, tendons, all those things, should resolve or be significantly better within a 3-month period. Okay. If they're not better in that 3-month period, likely the diagnosis is wrong or the treatment intervention for the diagnosis is wrong. So that's and it's very hard for me to say. Now, number one, being told that you have a strain of a meniscus is not possible because a strain affects only muscles. Okay. So that's number one, doesn't make sense to me. Have you had an MRI? No. So, yeah, and the only person that's assessed it has been the therapist you're working with?
That's right.
Yeah. So I think a second opinion at this point is warranted. Okay. I don't know if you need an MRI because I need to assess the knee in order to sort of determine that. The other thing, did you at any point take any rest whatsoever?
Yes. When I first injured the knee, I took probably a good week off.
Okay, yeah.
And then I slowly came back and again, worked with I do CrossFit.
Yeah.
So I worked very closely with my coach to make sure that the movements I was doing was heavily modified.
Yeah. So and here's a big thing with athletes or people that are as active as you are. Sometimes more time off is required. And, when you tell someone that and it's in the moment, they don't want to do that. But then looking back in hindsight, right now you've been dealing with this since May, would you have traded 3 weeks of being off so that you could feel much better today? The answer is probably likely yes. And so that's a big problem too with people who are athletic. Not a problem. I shouldn't say a problem.
But it's a mindset.
But yeah, it's a mindset. And also you're dealing with with a coach and their job is to essentially keep you doing the things you need to do. But sometimes I like to incorporate a good period of rest as well. Now, rest doesn't mean do nothing. It might be an active rest, but there's sometimes very much reducing the strain that you're putting through it is very, very important. So, again, and I'm sort of just thinking out loud here, but we do need to assess the knee to make sure that what's going on or what is going on, figure out what's going on and what the best course of action is at this point.
Okay.
Okay.
So next steps, I should
give me a call.
I'll give you a call. Okay.
Yeah, we can assess it for sure.
Perfect. Thank you very, very much.
No problem.
Thank you, Robin. Enjoy your Christmas. That number 1-855-55 Dr. Lou, DRLOU, or info at paincarecanada.com.
That's a big thing, eh? Yep. With athletes, they don't realize that sometimes when you're suggesting a period of rest, in the moment that you're telling them that, it's like, no way.
Like in one ear. Yeah.
And so I always like to tell people, what you're trading now is you're sacrificing now for the future you want later.
Yeah.
And so that sacrifice now, although it seems like it's going to suck right now, you will thank me one day, because this is a lot of the times what happens is people don't give enough time of rest or break from the aggravating situation.
Okay.
And things just don't heal right after.
And then it takes too long afterwards to get it done where you should have been.
Yeah. And I mean, if you've got an issue like that going on, continuing to put force through that knee, it's probably not a good idea. I don't know. I need to check it out to be sure. But that's already what I'm thinking. That probably some rest is probably very, very important. And rest is an important thing.
Yep, I like rest. Rest is good. A little too much, actually.
That's why it does nothing.
Nice midsection. That will do it for this particular show. We are back next week on the 29th following Greg, of course. You want to reach out to Dr. Lou now? No problem. 1-855-55 Dr. Lou, DRLOU, and info at paincarecanada.com. Suggest you do. Till next time, Dr. Payne Show, Global News Radio 640 Toronto.